Hello students and welcome to week 5 highlights in Advanced Pathophysiology. A few weeks ago we learned that reactive oxygen species ROS has a role in a wide variety of diseases and age-related disease including cancer, neurologic disease, type 2 diabetes, autoimmune, cardiovascular disease, infertility, and normal aging. Chronic exposure to ROS and decreased DNA repair can result in persistent DNA mutation. Accumulation of DNA lesions can lead to DNA double-strand breaks and disease onset and progression. Diseased cells can, in turn, develop ROS, that's the reactive oxygen species, and decrease the efficiency of the DNA repair mechanism. In a patient who has chronic bronchitis with a history of smoking, exposure to smoke damages airway epithelial cells that recruit white blood cells and initiate an inflammatory response. Reactive oxygen species and neutrophil protease damage lung tissue. Chronic inflammation continues even after the individual stops smoking. This week we discussed the diseases and the disorders of the endocrine system. The big picture of the endocrine physiology is that the glands themselves do not have freestanding functions, unlike the heart pumping blood or the gastrointestinal tract digesting and absorbing food, or the lungs matching ventilation and perfusion for gas exchange. Instead, these glands secrete hormones that travel through the bloodstream to target organs and tissues to modulate those organs and tissue activity. Endocrine disorders result from either a deficiency of the hormone, like the Addison's disease, or an excess of hormone, like Cushing and Graves' diseases. In some conditions, the pathogenesis lies in the receptor that do not recognize or act appropriately when stimulated by the hormone. For example, these are the androgen insensitivity syndrome or type 2 diabetes mellitus. In hormone deficiencies, the usual management is to provide hormone replacement. For example, insulin administration in someone with type 1 diabetes mellitus. In the case of hormone excess, a hormone secreting tumor may be responsible, and treatment involves removal of the tumor surgically or with radiation. Reduction of a hormone secreting tumor may result in a deficiency state that requires post-operative management with hormone replacement. Endocrine disorders are generally slow in onset and can result in substantial changes in function and even physical appearance before the patient presents to the healthcare provider with specific complaints. At that point, their history and physical findings may align with the classical descriptions of their conditions, or they may have atypical results that require further exploration before a diagnosis can be made. Endocrine disorders commonly fall into hormone excess, hormone deficiency, and tissue insensitivity to a hormone. Hormone structures are either hydrophilic or hydrophobic, with the hydrophilic hormones having the most significant effects through the membrane surface receptors and second messenger systems. Hydrophobic hormones travel in the blood bound to carrier proteins, and then they diffuse into the cells to link with receptors that bind to DNA, altering transcription and translation. The hormones of the posterior pituitary are vasopressin and oxytocin. They are examples of neuroendocrine signaling as they produced in large as they are produced in large neurons in the hypothalamus and travel in vesicles down the axon to terminal endings in capillaries in the posterior pituitary. Hormones release depends on action potential rather than releasing hormones. Since the axon travel in the pituitary stalk, they are vulnerable to compression due to brain injury. Although oxytocin secretion is generally minimal in the absence of labor and breastfeeding, vasopressin secretion is required for renal water conservation. Compression of the pituitary stalk that disrupts vasopressin secretion will cause a state of diabetes insipidus, that is the lack of vasopressin. This is usually transient. Anterior pituitary endocrine cells produce hormones with stimulatory actions on endocrine target glands such as adrenal, thyroid, gonads, or their modulatory actions on all body tissues such as growth hormone, GH, or breast, which is modulated by prolactin, PRL. Anterior pituitary hormones that stimulate growth and secretions of target glands are collectively known as trophin or trophic. That's the growth promoting hormones. The 6 major hormones of the anterior pituitary are adrenocorticotropic hormone, ACTH, thyroid stimulating hormone, TSH, luteinizing hormone, LH, follicle stimulating hormone, FSH, growth hormone, GH, and prolactin, PRL. ACTH stimulates the adrenal cortex to produce corticosteroids, corticoids, and androgen. FSH stimulates the production and secretion of thyroid hormones. LH and FSH stimulates the ovaries to produce estrogen and progesterone, and the testes to produce testosterone and sperm. ACTH, TSH, LH, and FSH function to promote their target glands' growth and promote target gland hormone secretion. These trophic hormones secretion is under positive control by hypothalamic releasing hormones and negative feedback control by target gland hormones. GH and PRL function differently in that they directly regulate target tissues that are not glands. Their secretion is regulated by other stimuli in addition to releasing and inhibiting hormones. And PRL does not have direct negative feedback pathways. PRL is under tonic inhibition by hypothalamic dopamine, and levels are usually low. Under estrogen stimulation, PRL's secretion increase during pregnancy, and PRL stimulates breast growth and lactation preparation. PRL inhibits gonadotropin releasing hormone secretion, which is the mechanism of ovulation suppression during breastfeeding, and in cases of PRL excess, that is prolactinoma. That's growth hormone secretion, is stimulated by hypothalamic growth hormone releasing hormone and inhibited by hypothalamic somatostatin. The actions of growth hormone depends on the stimulation of liver insulin-like growth factor 1 secretion. Insulin-like growth factor 1 feeds back to inhibit growth hormone secretion, while ghrelin from the stomach is a peripheral signal that stimulates growth hormone secretions. Insulin-like growth hormone factor 1 affects almost every body tissue, promoting muscle growth, bone growth, strength, and growth, and maintenance of many target tissues. The pathogenesis of type 1 diabetes mellitus is different from that of type 2 diabetes mellitus. In type 1, an autoimmune disorder in which immune cells attack and destroy insulin secreting beta cells, leading to absolute insulin deficiency that requires lifelong insulin replacement therapy. Acute complications of type 1 diabetes and insulin treatments are hypoglycemia and diabetic ketoacidosis. Type 2 diabetes mellitus is a disorder with variable presentation depending on genetics, ancestral descent, and individual differences. The pathogenesis is a combination of tissue insulin resistance that requires high levels of secreted insulin to normalize blood glucose levels, with beta cell vulnerability that leads to eventual failure and can lead to dependence on exogenous insulin. Both type 1 and type 2 diabetes mellitus result in insulin deficiency due to the destruction of insulin secreting beta cells. Both disorders are characterized by hypoglycemia and dyslipidemia and have similar long-term complications, including macrovascular disease that increase heart attacks, strokes, and peripheral artery disease. Other chronic complications are nephropathy, retinopathy, and neuropathy. Intensive glucose control reduces the rates of all these complications in both forms of diabetes mellitus. Gestational diabetes is usually diagnosed in the second trimester of pregnancy. It results from the increased insulin resistance due to the pregnancy-related hormone such as chorionic somatomamotrophin, and the fact that the placenta degrades insulin as well. The condition resolves after delivery, but a woman who has had gestational diabetes with one or more pregnancies is at a greater risk of later life development of type 2 diabetes mellitus. The autoimmune pathology to cause both hypofunction and hyperfunction of the thyroid gland is due to the destruction of the thyroid tissue in Hashimoto's thyroiditis, causes immune attack and tissue destruction of thyroid follicles. This acutely raises thyroid hormone, followed by prolonged thyroid hormone deficiency, indicating a primary thyroid disorder or hypothyroidism. Primary hypothyroidism occurs when the thyroid secretes insufficient thyroid hormone. Overt hypothyroidism will show up as a high TSH, low serum free T4, and signs and symptoms of hypothyroidism. Subclinical hypothyroidism will show up as a high TSH, normal serum free T4, and some signs and symptoms of hypothyroidism. On the other hand, in Graves' disease, the gland is targeted by anti-TSH receptor antibodies that bind to the receptor and mimic the actions of TSH, stimulating thyroid hormone secretion. These thyroid stimulating immunoglobulins cause goiter-like hypertrophy of the gland and persistent thyroid hormone elevations. Hyperthyroidism will show high levels of T3 and T4 along with the signs and symptoms of hyperthyroidism. Therefore, thyroid hormone excess results in the symptoms of increased metabolism such as weight loss, cardiovascular changes with tachycardia, elevated blood pressure, and wide pulse pressure, neurological changes such as anxiety, tremors, and hyperreflexia. Increased smooth muscle activity include frequent bowel movements, menstrual cycle abnormalities, muscle wasting with tired and achy muscles, heat intolerance with increased perspiration. And this concludes our week 4 highlights. Until next time, take care. Thank you for watching. Really appreciate you watching the videos. Thank you.